Neither. Dr. Duke Majan, we are broadcasting live spine surgery from Duke Spine Institute. Our patient is here because he has a gigantic herniation that has, at L4-5, that has migrated caudally. What that means is that the herniated disc didn't just go backwards like everybody else's does, but it went down behind the vertebral body. So I'm going to try to approach this just as you see the needle there at an angle that aims downwards. You see that? Show us that, Jordan. Yeah, very downward sloping angle. Why? Because I want to try to pick up the piece of herniation that went downwards. Shot? And that's going to be my best chance of doing it. Is he awake? Shot? All right, to do this I have to enter still at the bottom of the foramen, but my trajectory. Okay? Shot? All right, I'm almost there. Just need a little luck. Shot? All right, I need an AP view. No? Take your time. If you have questions, folks, feel free to call, write them up. All right, so we are right at the back of the disc. So far, things are looking really good. I think we're going to be able to get to this thing and fix it. I can feel, shot, the herniation. Oh, the trajectory is going to be a little bit different. You know, we're coming from higher up. Just try to get down low and get into that herniation as it's slipping down behind the vertebral body. This is a very special case. If you have questions, feel free to ask. All right, I think that's good. Give me an AP. AP in the foramen. It looks perfect. That's right where I want it. Just above the pedicle, right at the back of the disc. Honestly, that's as good as we can get it. All right. So at this point, what I need to do, have we numbed up? Let's go ahead and numb up the skin. This is, again, a very different type of surgery than what we're used to doing, okay? And that's because he has a caudally migrated herniation that is just below the vertebral body. It's a very, very difficult thing to treat. Whether you do open surgery or endoscopic, it's very difficult. I gave this patient an 85% chance of success before surgery. I did not give him 100%. I gave him an 85%, okay? And we're going to access 5-1 just in case. It's probably going to have to be a separate incision. Shot. We're never going to be able to get 5-1 through the same shot because I'm starting so high. Okay. Shot. Any questions, feel free to ask. In the meantime, shot. Henry, why don't you show us a nice video on the 30 different causes of back pain. Shot.
Copy that.
I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. So, just to give you a little background, this herniation will be the hardest one I've done all day. There's no doubt about it. This herniation, unfortunately, has gone from shooting out to backwards, which is normal herniation, to shooting downwards. And I've got to get the part that's shot downwards as much as I can. Okay, and that's the hardest part to get. Right now I'm dealing with the part of the herniation that's in the back of the disc. Okay, and there's some fat. That's normal fat. We always see fat in this area, in the foramen. Here's the herniation where it came from, right there. It's very tough. Look at all the gold is scar tissue, is calcium, and the white stuff is scar tissue. So right here is the back of the herniation. This is the part that is at the back of the disc. So we haven't seen the part that's gone down yet behind the vertebral body. But this, I'm trying to shrink as much of it as I can by vaporizing it, okay? That I told him there's no way I can get all of it. There's no way. No doctor can get 100%. It's impossible. The best we can do is usually 50, 60% of the herniation, which is typically enough to get the symptoms gone permanently. And I've had many, many patients where I got rid of 50%, 60%, and their symptoms are gone. They're very happy. Pain's gone. Very, very happy. And it's permanent, okay? All right, Luis, I've got to angle a little more medial. I want to get as much of the medial component as I can before I start working on the part that's migrated. So this is literally technically the most difficult surgery I've done all day. Now the last patient I did was a huge guy. He had a big spine. His spine was anterior. He had a big back. He was, I don't know, 300 pounds, maybe, right? 280. So he's a big boy, and he had a really bad anterior spine issue, but we got all three of those discs fixed quickly, efficiently. This patient is going to be my hardest for the day, no doubt about it. And he's hard for any surgeon. It doesn't matter who's doing the surgery. It's not an easy surgery. All right. I'll take questions. I believe in being honest. Yeah. This surgery is definitely the hardest of the day. Now you can see the part of the disc right there already that's moving south. Part of it, when I say disc, I mean disc herniation. Okay.
We have a question coming from Sonia on YouTube.
Sure, Sonia. Let me have the grabber.
Saying, Dr. Duke, I'm going tomorrow for both exams, and I will see you soon, most willing. How many times do I have to see you? Do I need a pre-authorization from my doctor?
Hi, Sonia. So, to answer your question, the best thing to do is to get your studies done, your MRIs, cervical and lumbar, and then to use our free MRI review. You don't have to pay for it. It's done virtually. It's done with Zoom. And all you got to do is go to the website and fill out the form. You know, it's going to ask you, where is your pain? You'll do one for your back, one for your neck, okay? And we would do 2 Zoom appointments. And at the end of those Zoom appointments, we'll know exactly what needs to be done to help you. All right, that's my best advice. So, 2 appointments, you'll have all the answers you need. As far as, does your insurance want a referral? I don't know. It depends on whether you have an HMO or a PPO. If you have a PPO, typically they don't require referral. Okay? If you have an HMO, it's a different story. They do require referral. All right.
At this moment, no current questions, so in the meantime, why don't we show the audience how it is a herniated disc causes back pain.
Luis, I want to put the dilator in there and try to get into the disc a little bit more. All right.
Stop out, please. Thank you.
Jordan, can you bring that fluoro in?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right. What is that? Why are we having noises like that? All right, good. So I'm going to take a little more of the herniation out from the disc, and I'll pull out and look down. Let me know when you're back, Henry.
We're coming back in 4, 3.
All right, welcome back. I wanted to get into the herniation a little more, so I just did that. And it's a good thing I did, because a lot of this herniation, come on, my foot was on it, restart it, let's go. A lot of the tell me when I can go. A lot of the herniation was inside the tear. So I want to go and get that. I want to get as much of that out as I can. So I'm very happy with my trajectory, the angle of approach. I'm coming from a top down because that's where the herniation went. It went outside and down. So I've got to be able to attack it from that angle, which I'm able to do now because of my trajectory, my entry point. This is all herniation. Now if you notice, we don't have blue stain because we did not do the blue dye. I did not start with a discogram because there's no reason to. We're not really doing a back pain surgery. We're doing a pinched nerve surgery. By the way, his nerve is so severely pinched that his toe like barely moved. He was a 4- before surgery with his strength in his toe. Basically, he couldn't even really move his toe. He just moved it against gravity, but that was it. He couldn't even really move it against gravity. All right, why am I a little hazy here? Is my focus just off? I don't know why the focus was off, but this is all part of that herniation. Look how scarred it is. It's really thick, really firm. By the way, this is what's pinching his nerve, right? So the nerve is soft and delicate. It's like soft tofu. This is hard, like a really hard cheese. And this hard cheese is squeezing his nerve really bad. Now, there's a lot of hard cheese, okay? And the nerve is being squeezed in many places. So I've got to try to unsqueeze in all the places the nerve is being squeezed. Any questions?
At this moment, no current questions, but we do have a comment saying, coming from a patient saying, would not go anywhere else, did me right up in 2018.
Oh, wow. 2018. That's like
7 years ago.
7, 8 years ago, yeah. Congratulations. Thanks for coming back on and sharing your experience with Duke Spine. I love to hear from my old patients. Nothing makes me happier. And that, by the way, people ask me, are there any patients who are willing to talk about their surgery that was done like 5 years ago or more? Here you go. Here's somebody that was done 7 years ago. And they're on the channel. Very happy with their surgery and their care. That's what we love to hear. All right. Once again, this is the hardest surgery of the day for me because this is what's called a caudally. Caudal means towards the tail. Caudally migrated disc herniation. It's the worst of them. They don't get any harder than this. This is the epitome of difficulty, which is why if you watch a lot of my surgery, you'll see that I did a very different approach. I did a different angle approach. I actually angled downwards. I came from higher up and angled downwards because that's where the caudal migrated fragment is. It's down. This is all part of it right here. But this is not the farthest part south. We haven't seen that yet. But this is all part of the herniation. By the way, look at the little marks on the metal. This is steel, the German stainless steel, the best steel in the world. This is surgical steel, very strong. And look at those marks. You know what those are? Those are from the laser hitting the steel and melting it. Those are all melt marks on the tube. That's how powerful this laser is. A lot of people think, oh, the laser can't get rid of bone spurs. Oh yeah, the laser can melt steel. You could cut a piece of steel with this laser. This is a holmium YAG laser. It's a medical laser. It's very, very powerful. We don't even have it turned up all the way. We have it at about 50% of its power right now. And if I turned it all the way up, it could easily cut through steel. All right, here's more of the herniation. When I got in and I saw this, I realized I gotta be more aggressive at getting this out. So I changed my angle just temporarily to attack this area more. All right, any questions?
Yes, we have a question coming from Sonia once more on YouTube.
Hi, Sonia, welcome.
Saying, I call my UHC doll complete, and they said all I needed was authorization from my doctor to talk to you. And he said that you have to ask him for it. So I don't know what to do. What do I need to do, Dr. Duke?
Well, first of all, do your free MRI review. And once you know what you need, then my office will send your doctor, will give you a letter requesting your doctor to authorize or approve your surgery, your treatment. But let's at least figure out what you need first. And then we can give you that letter or that form, and you just take it to your doctor and ask them to approve your surgery. And then you'll have that. That's what I would do. That's your best choice. Okay, you don't need your doctor to authorize anything right now because what we're going to do is free. We're not going to charge you. So we're not going to charge your insurance either for your MRI review. The MRI review is free. That's the best thing we can do for you, is give you a diagnosis and tell you what needs to be done. That's diagnosis and a treatment recommendation, and you don't even have to pay for it. Neither does your insurance. We want to help as many people as we can, so we do that part for free. Once we know what you need, that's when we need your doctor's help. All right, any other questions?
At this moment, no current questions.
So we are near the back of this L4-5 disc once again. I've got about 15 minutes left. Berndes? This is really, really stuck down material, really thick, really difficult to remove. Just about at the back of the disc, this is where the herniation sort of changes direction and goes downward. So we're gonna finish this part as we always do, and then we're gonna have to follow the herniation downward.
We have another question.
Yep.
Coming from Paul on YouTube.
Sure, Paul. Yep.
Asking, where are the nerves that are being decompressed? Can they be seen while you are doing the surgery?
Hey, Paul. Great question, Paul. The nerves are right outside this tube. One of the nerves is at 12 o'clock, and the other nerve is at 3 o'clock. So 12 o'clock is just past where I'm operating, and 3 o'clock is to the 3 o'clock position. We don't want to see the nerves, because if I see the nerves, that means they can be damaged. We don't want to see them. We want to work below it and lateral to it, because once the nerves are exposed, then we run the risk of damaging those nerves. We don't want to damage them. Wow, so much here. Hold that tube. You cannot let go of that tube. You hear me? That tube comes out, we're SOL. Grab her. All right, so normally we would be pretty close to being done. Hold the tube. Got a piece of bone spur. There's a piece of herniation. Oh, that was a pretty good one. Nothing humongous to write home about. There's a piece right there. Oh yeah, get the tube, please. Oh yeah. All right, that's a good one. That's worth showing you guys. Turn the light. Check it out, Henry. See that?
Yes, we do.
Thank you, Luis. That's a good sonometer. Okay. Now we can't, go home now and have Papa John's pizza. We're not done yet because there's more of that we need to get out. Okay, but that's a very nice piece. And I think there's going to be a few more. How's the irrigation? Remember, this herniation we're dealing with is not one herniation. It's about 40 pieces. And every piece I get, some are big, some are small. Oh, there's another one. But every piece I get, that is a little more pressure off the nerve, okay? And this game of spine surgery, this game of decompression is what it's called, is really a game of just getting enough, right? Getting enough decompression done that the patient is happy and doesn't have symptoms. But there is no, please, there is no, you get in there and you slay one dragon and then the game's over, right? It's really about taking out as many of these little zombies as we can get. Each one of them is adding to the misery and suffering of the patient. So the more pieces I can get out, the better. That's the back of the bone right there, that lump. And this is still herniation right here. So I'm going to keep working on it. I'm going to have to change things a little bit. Change my angle, pull back a little bit. Laser. And I just got to keep working on this. Hopefully remove enough that his nerve is happily unpinched. That makes sense.
No current questions. So in the meantime, why don't we show the audience of how it is the surgery cures back pain?
Sure.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, we just pulled out a nice chunk, about the same size as the last one. And unfortunately, hold on, what I'm seeing here is that the herniation is not just one nice big piece. It is many little pieces, which is what I was worried about. And it just means we're going to work at it and try to get as many as we can out. But I was kind of hoping that we could go in and just take one big piece and kind of have that aha moment where you're like, oh yeah, we came, we saw, we kicked its booty. This is going to be, unfortunately, just taking out as many little pieces as we can. See all the little pieces that I'm talking about? Like they're just kind of floating up and out.
Yes, we do.
How's our irrigation? Okay,
We have a couple more questions.
I will take your questions.
Next one is coming from Faisal on Facebook,
Hello, Faisal, welcome back.
asking, can you get the same amount of the herniation required to cure your patient's pain as well as done, or as well as a well-done fusion surgery you would do? I feel with the laser surgery, you will have to be more accurate, whereas in your fusion surgery, you'll be naturally being removing more disc material plus the annular tear. Thank you.
Great question. In this particular case, just one case, where the herniation is so unusual, if I did a laminectomy, osteotomy, fusion, I think we would have a higher chance of success, okay? But you have to remember one thing. The patient decides what surgery the patient gets. And I just laser 85%, fusion would be 95%. And they didn't want the fusion, and I personally wouldn't want the fusion either. Okay? If I knew that a Dr. Duke Majan could do the surgery with an 85% success rate, I would choose that over having a fusion. Okay? So, in the end, I don't tell my patients what to do. I give them choices. And the choice this patient made, which is the same choice I would have made, was to do laser. Okay? Knowing that there's a chance it won't work. That there's a chance it won't work. Okay? That's really what it comes down to. And the truth is, all surgeries, and I mean all surgeries, have a chance they're not going to work. So in this case, the chance is pretty significant. It's not low. It's not small. It's substantial. It's 15%. To me, that's high. Normally, my chance of not working is about 1%. So to have a 15% chance of not working is a lot higher than normal. For me. I don't like it. But the alternative is a fusion. And that is a much more invasive surgery and higher risk of complications. So, you know, that's the thing about it. In the end, the patient has to choose. Not me, not you, the patient. And my job, this is all the herniation that migrated. Okay? You guys see it? It's right there.
Yes, we do.
Unfortunately, it's not coming out easy. I'm grabbing it and it's stuck. It's scarred there. Okay? but that's it. And I'm just getting a little bite at a time. So imagine killing an elephant with cat scratches, right? My wife always says that to me and the kids. How do you, it's horrible. She says, how do you eat an elephant? I always say, well, first of all, I would never eat an elephant. Right? She says, one bite at a time. Right? So this is an elephant. We are literally eating an elephant here. This thing is huge. But we're taking it one bite at a time. And the reality is we're not going to get 100%. We already know that. Oh, look at that. I think I can get some good coverage right there. I just need the laser. We already know we can't eat the whole elephant, but we're going to try our damn best for the patient. No. No, Grabzilla is too dangerous. See, Grabzilla is a blind grab, right? And I can't do anything blind. I have to see. The only problem is I get a little bit of epidural bleeding. That's where we're getting that red. Is coming from some veins behind the vertebral body. But you can see the vertebral body right there. We are literally behind the vertebral body, and the nerve has been pushed back, and there's the herniation right there. I just need to get the laser right there. Yeah.
We have a couple more questions.
I'll take them.
Next one coming from Paul, once more on YouTube.
Can you help me get the laser to 12 o'clock? Oh yeah, very nice, very nice. Yes, Paul, on YouTube.
Asking, so the goal is not to remove the entire herniation, but just enough to decompress the spinal
Yes.
cord, or in this case, the nerves at
Yes.
this level?
You are correct, Paul.
it's just-
100%.
Is it just less pressure equals less pain?
No, what it is the nerve has space around it, all right? And you're born with that space. And the truth is, it's far more space than you need, okay? But when you start to narrow that space, called stenosis or narrowing, from a herniation like this one, then it's at some point the herniation gets so big it crushes the nerve, right? Too much. It crushes the nerve too much. In other words, it's kind of like taking someone's arm and squeezing it. You can squeeze it a little bit and it doesn't really hurt. But if you keep squeezing it harder and harder, eventually it's going to really hurt them. It's the same thing with the nerve. The nerve can be pinched a little bit, but it cannot be pinched too much. And right now, this is being pinched too much. So my job is to take some of the pinching away, but I can't take all of it away. Nobody can. There's no surgery in the world that can get all of it. That's the problem. And it has to do with the angles, and it has to do with the structures that are there. Even if I did the laminectomy, okay, and I open this guy up, even if I did that, and I am probably one of the best in the world at doing that, I would still not get 100% because it's not possible. Laser. I would still leave about 30%. Now, I would get 70. I won't get 70 with this treatment. I'll get 50 at best. But with 70, guaranteed, pretty much guaranteed he's going to be decompressed. Yeah, we're almost done. I've got about 5 minutes left. Okay, so I told the patient, if I do a more invasive surgery, there's a higher chance of success, but it would require a wide decompression, osteotomy, laminectomy, and fusion, okay? And he said, no, I want to try the laser, and if it doesn't work, we can always do the fusion. So that's the plan. But I think this is going to work. Maybe I'm just too optimistic, but I really think it's going to work. I'm almost done. I've almost gotten everything I can. Let's have the grabber again. So we're actually outside the disc right now. You guys see the bone down there? I don't know if you guys can see it. The disc is here. I'm inside the disc. I'm outside the disc, okay? That's the back of the vertebral body I'm banging on. That's the back of the vertebral body up there. The herniation that normally we deal with is all right in here, and that stuff's gone, okay? We've gotten rid of it. We are now working outside the disc, and the nerve root, the one we want to protect, is right there. You guys see that white thing? Okay?
Yes, we do.
So that's one that I want to protect. The other one is more medial. So I'm trying to just get my aim here with my scope and remove as much of that stuff down there as I can. You can start to see you got a facet joint too, but I want to take one more bite at the apple right there, okay? That's fat and little veins, and I can go right through that to get to some more of the herniation. That's what I'm going to do right now. Again, you know, the other thing as a surgeon you got to know is you got to know your limit. You got to know when you've done everything you can. And I'm just about at that limit right now. I'm literally just picking away at millimeters. But sometimes to win, you have to get a millimeter. It's just a millimeter. That's the difference between winning and losing here. So that's why I take every millimeter serious. All right, wipe that. I want to just take one more look. I'm going to really pull back, see what we got here. We're going to be looking at the facet joint right there. You see the facet joint? That's the outside of the facet joint. That's what limits us. I can go through the facet joint, start taking some of the facet out with the laser, but then you get to a point of diminishing gains where you're removing bone, you're creating more bleeding, and you're not really making any more progress. And that's what I want to avoid. I don't want to create damage and not have a benefit for it, for the patient. All right, I think that is it. Yeah, that is the facet. And I'm trying to grab the last few pieces of herniation that I can. That was a decent piece, so it was about a millimeter. And the rest of this is facet. And I could just take one more look right here. We're almost done. Any other questions?
Yes, we have about 3 questions coming from. First one coming from Larry on YouTube,
All right, Larry.
asking when you do the piriformis release, how does that affect the movement or control of the leg in the future and strength?
That's a great question. I appreciate you asking me. So Larry is smart. He's saying, Dr. Duke, all right, you're relaxing a muscle. You're basically detaching a muscle that's damaged and it's causing all this pain. But isn't that muscle necessary? The answer is all muscles are quote unquote necessary, but of all the muscles in your body, the one that you don't need at all is that piriformis muscle. Why? Because if you break it down, what do muscles do? Okay? Muscles move bones. They move bones around joints. By the way, I'm still going here because I was actually able to snag a little piece right there, and I'm trying to see how much I can get. But basically, muscles, they move bones around joints. That's what a muscle does, right? So the piriformis happens to move your hip, and it's called an external rotator. It moves your foot outwards. But you've got 4 other external rotators that are much better at moving your hip. And the piriformis does very little. And when I remove the piriformis, people don't even notice it's gone. Like they have no loss of function. 1 minute, they have no loss of function. They have no loss of function. Okay? So that's how useless that muscle really is. It just hurts, that's all. It doesn't really do anything else. It is an external rotator, but it's very minimal effect on rotation of the hip. Very minimal. All right. Pretty much done everything I can at this point. There is still some herniation there. I can't reach any more of it. I can't get any more. But, huh? What? What were you saying something? I just can't get any more. Okay? So, I've gotten all that I can. Maybe one more zap right there. I'm really angling my scope medially as much as I can. Give me 12 o'clock. Uh-huh.
We have about 2 more questions.
Yeah, I'll take them.
Not a problem. Coming from Faisal once more on Facebook, asking if you have a torn muscle in the back causing back pain, would you do a surgery to put the muscle back in place? Do you go back muscle repair surgery, or do you let the orthopedic surgeons do that? Thank you.
Yeah, there is no muscles that tear in your back and cause back pain. I don't know of any situation where that happens. I don't believe there's such a thing. The only muscle that causes back pain that needs to be repaired is the piriformis muscle. Now, you do get muscle spasms, muscle tightening in your back when you have a painful disc or a painful facet joint or a painful SI joint. So those, or a fracture. So any primary cause of back pain, such as fracture, disc pain, facet pain, SI pain, will cause muscle spasms, okay? And those muscle spasms are what you're feeling. But you never ever cut a muscle or try to do anything with the muscle. We're done. Yeah, 5-1. The disc, I sounded it. It looks good. It's not causing any problems. So it's just this 4-5. 5-1, we cannot get to it. Some pretty good pieces. We have a collection, but here, I'll show you guys a couple of pieces. We have more that have fallen into the bag and whatnot, but here's a couple of pieces of that herniation right there. You guys see it?
Yes, we do.
All right. So, did I get it all out? Absolutely not. Did I have to leave some? Yes, I did. Am I disappointed I couldn't get more? Absolutely. Did I get enough? We won't know until tomorrow. Tomorrow we'll know. Tomorrow when we examine the patient, find out how they're doing, how they're feeling, we'll know. But that's it. As I say, the proof is in the pudding. A lot of surgeons look at MRIs and X-rays to judge their results. I don't. I look at the patient. And if the patient had a successful surgery, if the patient still has the same symptoms, then I didn't have a successful surgery. Now, they're going to need some time to heal. I told them the numbness that he has in his foot will take up to a year. The weakness in the toe is very bad. It could be better tomorrow. It could take a year. But I think we got enough of the herniation. I just don't know for sure. All right, any other questions?
Yes, we just have a question coming from Charlie on YouTube. Oh, and we have another question coming from Sona. First question from Charlie asking, have both sides, this is Andor seeking advice, have both sides, leg and foot numb, neurologist checked for neuropathy, neurosurgeon did not think spine was causing my problem, eval normal, EMG normal, next is peripheral nerve biopsy. Is this a common cause?
It's not a common cause. It sounds like a pretty rare cause. But before you go for a peripheral nerve biopsy, I strongly recommend you do an MRI review with me. It's free. We can have it done within a week or two. My advice is unless you have a really good reason for a nerve biopsy. The thing is, I have found that the disc is the cause of those type of symptoms. Even though the EMG is normal, you have to have 20% damage or more to the nerve before the EMG shows up, and you have to have at least 2 weeks of damage for it to show up on the EMG. So you need 2 weeks minimum, and you need 20% or more damage. It could be that your nerve is irritated with inflammation. I will be able to tell you that based on your MRI, and I strongly recommend you do the MRI review with me before you do anything else.
And then lastly from Sonia, once more on YouTube, asking, Dr. Duke, how fast can I get an appointment?
If you want to come in the office, I'll see you tomorrow or next week. If you want to do an MRI review by Zoom, You need to fill out the form and send us the MRI. As soon as we get it, we'll book you that Wednesday or Friday. We do them on Wednesday and Friday.
And that is it for questions.
Have a wonderful evening. We're all done for the day. Thanks for joining us. We'll be back next week.